My name is Lou Grabowski, and I am the chair of the board of the trustees of the Retina Foundation. And I'm here to welcome you to what will be a very riveting and enlightening presentation on things that we're doing at the Retina Foundation. I thank you very much for being here this evening, and it's a great gathering. And certainly for us, this is our second in-person gathering since, the pandemic session. And I think it's just about over, but I won't call it completely over. But we're all getting out now, and we're very pleased with that. And the visionary luncheon we had in May, which I suspect many, if not all of you were there, was just a fantastic in-person event for the foundation and a very successful one. So thank all of you who participated in that and had an opportunity to hear what we're doing at that time and meet some of our leadership and scientists there. Tonight's Eye on Innovation series is something we started back in 2018 with the help of the Rosewood Foundation and Carolyn Rose Hunt family, who are the primary sponsors again tonight. But it's our way to provide periodic updates on the things that we're doing at the foundation to help prevent loss of vision and restore sight. And it keeps our patrons and donors and volunteers and friends and the community up to date on what we're doing. And so these sessions hopefully are very helpful. And tonight's session deals with the next generation of stem cell research as it relates to age-related macular degeneration. And we're pleased that we have with us both our leader at the Retina Foundation, our CEO and Chief Medical Officer, Dr. Carl Chalky, and we also have joining him our newest addition to the scientist group at the Retina Foundation, Dr. Sri Sripathy. Sri joins us from Johns Hopkins, and he is his research and innovative movements are directed toward stem cell application in age-related macular degeneration. And I know you're going to find the discussion, I hope, very enlightening. As we begin that, I wanted to do a couple things, but get the program started, and that is to thank our primary sponsors for the event, which are the Rosewood Foundation and also the Carolyn Rose Hunt family. And they have been with us, as I mentioned, from the very start in 2018 and have been sustaining sponsors. We also have John Minsky here from the Rosewood Foundation, who is the president and CEO, and thank you for being with us this evening. I'd also like to thank Dr. Bill Hutton. I think Bill's somewhere close at hand, there he is, and the Mason Brown family Foundation, who sponsored our terrific cocktail hour and gathering. Thank you, Mason Brown and Bill. Appreciate that. Now I'd like to ask a member of the Carolyn Rose Hunt family, the granddaughter of Mrs. Hunt, Julia Sands Cunningham, to join me on the podium to introduce our speakers.
It is an honor to be here with you all this evening for this Eye on Innovation series discussion. It is truly an exciting time at the Retina Foundation. The stem cell research and breakthroughs in age-related macular degeneration that Dr. Chalky and Dr. Sripathy are making today will no doubt change the future for a countless number of people tomorrow. Some of you may know that my grandmother lived with AMD for many years. It was her own personal experience of slowly losing her eyesight and her freedoms that inspired our family and the Rosewood Foundation to support the Retina Foundation. Our organizations share the same vision: to make meaningful contributions to improve the quality of life for present and future generations. We are proud to continue our support of the Retina Foundation as it leads the charge in innovative research and therapies for AMD and other eye diseases.
Julia, thank you so much, and really the support of your family, the foundation, just can't put into words the impact that it has for all of us, and hopefully for the patients that we take care of and will be taking care of in the future. I want to just spend a few minutes about why we're here tonight in kind of a 30,000-foot view, and that is when we think about diseases. We think about vision diseases, and at the foundation we deal with all ages. We deal with patients who are older, we have patients who have genetic diseases that affect their eyesight, and we have younger patients. And vision truly, I always tell people, it's kind of a theme that I always like to kind of refresh people's memory and kind of thinking, is that we wake up every morning and we just see. It's a very kind of passive thing. And for those of us who still have good vision, we take it for granted, right? And yet, that isn't the case for a lot of people. And especially as we're getting older and we're living longer, right? This disease called age-related macular degeneration is really affecting more and more patients. And it really is something that, on a personal level, when I see people as they get older, and they're more healthy, they're being active, and yet now they're limited by this inability to drive, see their grandkids, things like that. I think it really inspires me, and I know it's inspiring many of you all to really make a difference. And that's really why we're here tonight, is to talk about some of the newer technologies that we are doing and that we will be doing at the Retina Foundation. One of the unique features of the foundation is that we have this model where we can really incorporate patient care into our research on a day-to-day basis. All of the patients we see are in some type of research protocol. We don't charge them. It's not like a normal clinic where the first question was the first question that they ask you when you walk into a doctor's office. What's your insurance card? Here, our first question is, how can we help you? So that's the difference that we'd like to make in people's lives, and that's what we try to do. We make it very patient-centric. We've worked with investigators across Dallas, the area, people at SMU we've worked with in developing interesting technologies. You'll hear about that in November if you show up again, some of our innovative technologies that we've worked with other folks as well. And so it's really a unique aspect that we have here in Dallas and in North Texas to be able to offer patients hope and in some cases real benefit in terms of what we can do for them. So we're talking tonight about a unique technology, stem cell, and I'm really honored and proud to invite and introduce to you all Dr. Sri Sripathi. We, several years ago, made a decision at the foundation that we were going to expand. We were ready to expand our kind of repertoire of work that we were doing, and we went around the country, and I can tell you that we found literally the best of the best. And as I tell people, he spent time at Hopkins teaching Hopkins folks about stem cells. So we were very honored to have him decide that he wanted to join us. So we're going to just start with some very kind of basic questions that I think is for all of us who are thinking about this. You're going to hear him talk about stem cells, but you're going to also hear him talk about a very specific type of stem cell called an iPS stem cell. And so I guess I'm going to start this conversation by asking you, tell us about stem cells and tell us about iPS cells and kind of what you do and how this whole works.
Yep, thank you. First of all, every cell in our body has the potential to go back to its original stem cell states. The stem cells has the unique property, we can convert them into any type of cell in our body. It could be heart cell, a muscle cell, a brain, or eye cells. In the lab, we're interested in generating induced pluripotent stem cells. By using a Nobel Prize-winning technology, we create iPS cells. So iPS cells are very similar to embryonic stem cells, but these are not derived from the embryos. Rather, we take these stem cells from your blood or skin cells. All we need is a tiny bit of blood sample that we convert into a stem cell. And then we, in turn, again convert these iPS cells into eye cells. So let me show here a quick glance. So if you see here the eyeball with the retina, the central portion of retina called macula, which is responsible for the central vision, for the driving a car or reading a book. The healthy macula plays a key role. So if you see the graphical representation of the retina, you could see many type of eye cells. So we are particularly interested in these cells, a monolayer of cells called retinal pigment epithelial cells, which are necessary for our vision, leading to the degeneration of these cells leads to the AMD. So here, this is the picture of stem cell-derived the retinal cells, 2-month-old RPE cells we generated in the lab. And also, using these stem cells, we make the 3D organoids called mini eyeballs. So here you can see the bunch of eyeballs contains all the cell types that we have in our retina. So using this technology, we can study how the AMD is going to progress, and in turn, we will find out the better cure for the AMD.
That's pretty cool, huh? I know for me it's pretty cool when I see little mini eyeballs, so everybody can sit there but for me it's very exciting. So let's talk a little bit about, and of course, we take blood from anybody and you grow these iPS-derived stem cells, now that we all know what iPS-derived stem cells are. Talk about, the idea that is there a personalized approach to that cell? If I take it from someone like John, not picking on you, John, but we'll be taking blood from you afterwards, so don't worry. But if we take John's cells, does his genetic material, his imprint, stay on those cells so that it really becomes a personalized cell line from him or from anybody else?
Yeah, great question. So these stem cells have I told you, the unique property. So these are the incredible source for the personalized medicine because it exactly contains the same genetic information. If we take blood cells from the John, and then when we convert into the retinal cells, the genetic background is same. So these cells are very specific to John. So these cells have unique property that John have. So using these stem cells, we convert again, as I shown you, 2D and 3D retinal cell types. And then we'll test for hundreds of thousands of novel drugs. Those are either novel or FDA-approved drugs to find out the particular drug which protects these retinal cells against some stressors or toxic things. So these are unique to the patient. Again, we are using a Nobel Prize-winning technology to modify these cells called the CRISPR-Cas9 genome editing technology. So using this novel technology, we can precisely edit the gene. So a particular gene is causing the AMD. So, and also we know many risk factors that are known for AMD. First, in the stem cell sample, we'll look for whether he has any mutation that's relevant to the AMD. Then, using this new technology, we can edit the gene. We can correct the gene or reverse the mutation so that he could see better way. So yeah, this is an incredible technology we're gonna use for the new AMD therapy.
Right. So it's really, just to be clear, it's the highlight of personalized medicine, right? So we will have, and the idea eventually is we will have stem cells, these iPS stem cells from patients that we see, and we can then look at specifically for that patient what could be driving their macular degeneration, as well as the idea that it's unique therapy which could benefit them on a very unique level. So it really is kind of a very exciting technology, and the fact that we'll have that here at the foundation, I won't ask for volunteers yet, but yeah, I think it's going to be a very exciting way for us to study this specifically, and because we have such a large group of already AMD patients that we've been following, we know from historical data kind of what's been happening to them, and then to understand their cells at the molecular level will be a very exciting area of research. Your timelines for showing up, for one thing, but also maybe share with us, I think those of us who are in research, it's a tough thing. Most things don't work. You go into work, you do stuff every day, and it doesn't work, right? And you come home and you go back again, and you go back, it's like, being the Detroit Lions, right? I mean, they just keep showing up for work. Got to give them credit. So hopefully there's no Detroit Lions fans here. But it's a tough business. And so maybe, first of all, share with us some timelines. I know you were here today renovating thinking about the lab.
Therapy.
Right. So it's really, just to be clear, it's the highlight of personalized medicine, right? So we will have, and the idea eventually is we will have stem cells, these iPS stem cells from patients that we see, and we can then look at specifically for that patient what could be driving their macular degeneration, as well as the idea that it's unique therapy which could benefit them on a very unique level. So it really is kind of a very exciting technology, and the fact that we'll have that here at the foundation, I won't ask for volunteers yet, but yeah, I think it's going to be a very exciting way for us to study this specifically, and because we have such a large group of already AMD patients that we've been following, we know from historical data kind of what's been happening to them, and then to understand their cells at the molecular level will be a very exciting area of research. But I want to get a little personal, if that's okay, with Dr. Tripathi, and just kind of talk about, first of all, your timelines for showing up, for one thing, but also maybe share with us, I think those of us who are in research, it's a tough thing. Most things don't work. You go into work, you do stuff every day, and it doesn't work, right? And you come home and you go back again, and you go back, it's like being the Detroit Lions, right? I mean, they just keep showing up for work. Got to give them credit. So hopefully there's no Detroit Lions fans here, but it's a tough business. And so maybe, first of all, share with us some timelines. I know you were here today renovating thinking about the lab.
So the unique thing about this boarding school, they have like a free eye hospital associated with the school. And I used to play in that hospital after hours, actually. So that's like, I used to see the patients having the eye patch when I was like in 5th grade. And also, the boarding school has a nice opportunity for visually impaired students, totally blind kids. So I used to teach Braille. So I used to read the lessons so that they can listen, and they in turn put that stuff in the exam. So that's what I was interested in, a little bit of eye thing, but I was kid. But again, when I graduated with master's in molecular biology, I joined an eye institute in India. I briefly worked there and taking care of the premature babies who has like the irreversible blindness because of their retinal detachment. So I was involved in studying their genetics, how this blindness occurring in the premature babies. So then I decided, I want to pursue my research in the eye field. So obviously, the United States has a great opportunity to pursue my dreams. And then I moved to Michigan for my PhD, where I first grow these retinal cells from the cadaver eyes and then culture them to understand how these degenerate in the AMD. After my PhD, I continue my eye research, especially stem cell research, at Johns Hopkins Wilmer Eye Institute, the premier place for ocular research. So I've been there for the past 10 years as a fellow, as the faculty, and now I think I want to contribute more to have an independent lab. I had like many great things about the Retina Foundation and Dr. Chalky, and then I decided to continue my stem cell research with great support, people like you and then community. I really want to flourish my stem cell research at the Retina Foundation. As a clinician, you see many patients every day, especially AMD patients. So what do you think the stem cells plays a key role in changing the AMD patient lives?
Right. So yes, I'm a clinician. We see lots of patients with various stages of AMD. Clearly there are some early stages in which, while the stem cell direct approach therapy-wise will not yet have a role, it'll help us understand, because we can just draw blood and understand even at early stages or intermediate stages what's driving and hopefully have therapies. But clearly, the kind of holy grail of stem cell that we read about in the various magazines and everything is, of course, the whole idea that you can essentially put back and replace the tissue that was degenerated, right? And one of the exciting things about these iPS-derived stem cells in particular is that, unlike a normal organ transplant, when we think about stem cells, in many ways it's like an organ transplant. You're putting back something that is foreign. However, because these are grown from the patient, the idea of rejection doesn't exist, because obviously the genes, the genetics of rejection are not the same, because these are your own cells. And so we've been involved in various aspects of stem cell therapy. This is, for example, kind of the stage that we're still kind of at. So if we look here, this is a patient with severe macular degeneration. Again, for those of you all who aren't familiar, basically here's the optic nerve, here are normal vessels, and there should be good, healthy tissue in the middle, and instead you can see all these whitish areas, and this is essentially all of this tissue has degenerated. And so this patient would have severe vision loss, would be unable to drive, see their grandkids or anything. And so here's an example of stem cells that are placed on a little matrix and then placed surgically under that area and trying to replace it. So the idea of stem cell therapy, we've been involved in 2 stem cell trials already at the Retina Foundation. We're one of the few groups in Texas that has already been involved in stem cell therapies for macular degeneration. Clearly, this idea of rejection was one of the key limiting factors in this treatment, and that's one of the reasons that we think this iPS-derived approach is so valuable. But I think the other thing that stem cell as a clinician does for me, and I think it's also important what we do for patients, and I think the most important thing that I always give to every patient I see is hope. That's the number one thing. I don't want anybody walking out of my clinic thinking there's nothing else that we can do. And so everybody gets a message of hope. And so stem cell, I saw a patient this morning, very nice lady. She's been involved in lots of our research trial, and she has severe macular degeneration like this patient has. Wonderful woman, inspires me because despite her severe vision loss, she is always smiling, always laughing, always joking, and it's just, incredible. And so I want to be able to tell her, like all my other patients, that one day we're going to be able to replace those cells that are missing and hopefully give her back some of her vision. So that's really the other key aspect of stem cell therapy that I think is so critical and that we'll be able to offer patients who we see, and that is this idea of hope. But it doesn't just stop at macular degeneration. The stem cells that Dr. Sripathi was talking about, as he said, they can be put into any cell type in the body. So we have patients with retinal degeneration where they've lost retinal tissue. The McKeever brothers, for those of you all were here at our visionary luncheon, you saw the McKeever brothers. One brother is unaffected, one brother is affected, has lost central vision, obviously is still incredibly active, but hopefully at some point, and we talked to them about stem cells, we can provide other patients beyond just macular degeneration patients this idea of regenerative medicine, hope that in fact there's a way to gain some of that vision back. So that's really the message I want to leave people for this discussion tonight, is incredibly exciting time for medicine, for, I think, North Texas, for us, and of course for the Retina Foundation. And I hope you all continue this journey with us as we really break into this new era of treatment and ideas for medicine.
What are the issues of how these new cells connect with the optic nerve?
Right. So as you know, the retina is an electrical circuit, right? It's very much like a microprocessor. And so one of the challenges that we've had in stem cell therapy is, correctly to your point, making sure that all the connections kind of make it, right? The wonderful, beautiful thing about iPS-derived cells, and I'll let him comment on the organoids, right? So if you think about an organoid, what you were seeing was a fully connected retina.
Yep.
So when we think about transplanting for those people who've had more severe degeneration, where a significant portion of the retina is missing, we could potentially put back a significant portion of that circuitry. And because these are your own cells, there isn't the rejection. What we have found in the past is that when there's a rejection, these connections just don't take place, right? The cell doesn't to be there. So we're hopeful that with iPS-derived stem cell of any cell, pigment epithelium, photoreceptor, whatever cell, that the body is more likely to accept it as one of its own, so to speak, and make those connections.
Over the past few years, I've heard more and more about people storing their newborn baby's cord blood. Do you think that could potentially play a big part in this kind of research in years to come?
Yeah, that's a very nice, to have the stem cells stored in future if we have any problem with any organ in our body. We could potentially differentiate into search organs. Even if we don't have that facility or like chance, we could still convert the particular baby's blood or skin cells into the stem cells, so-called pluripotent or iPS stem cells.
Is there a broader application for, could someone else's stem cells be inserted into someone else's body and expect the same kind of result?
Yeah, so clearly genetics play a big role, right? So, it's not, for example, cord blood has been sometimes used for the parents, not just for the kid. So there is these HLA antigens that are involved in rejection, and there's a genetic component. The truth, though, is, and Dr. Sripathi can talk about, in some ways, how relatively easy, at some point, it is to grow these cells, right? And so the advantage far outweighs the labor it would take to grow these cells individually for every patient. The truth is, and maybe I'll let him speak to, how difficult it is, but if you think about it, it's the ultimate way you'd want to transplant tissue is specific to you. And as long as, and maybe you can chat for just a little bit about how difficult it is once you've got this down, right?
Yeah.
Teaching everybody,
Yeah.
and teach me. Talk about a little bit about just technically how difficult is it really to do this? This sounds like it needs a team of 100 people, but tell us a little bit about what it really takes to achieve something like this that you could then personalize the approach as well.
Yeah. So the first thing is these stem cells are very specific to the patient because we are getting a sample from the patient. So all we need is a tiny amount of blood samples. So we take the blood, draw the blood, and then we convert those cells into stem cells. So now these cells have the property can generate into any type of cell. So use those particularly patient-specific stem cells, and then we convert them into whatever the cells we lost in our eye. We convert them in a dish we called a disease in a dish approach in the lab, and then we culture them in a very careful condition so that they don't have any immune rejection when we transplant back into that specific patient's eye.
Yeah. So technically, it's really pretty amazing. You have to have the know-how and then the experience, which is why, thank heavens, he's coming. But again, it's scalable. Let's put it that way. So it's not going to be something that I think is going to. And I think one of the other things, just to kind of share with you what another aspect of the Retina Foundation that we're very proud of, and that is, we're not a pharmaceutical company, right? So we do research, but one of the things that we do is we partner and license our technologies. We've licensed already 3 technologies to commercial entities who will continue to develop those. So we have partners on the commercial side who take our technologies, who will take Dr. Sripathi's stem cell technologies, who've taken some of the technologies that we've developed at the foundation. So I think one of the important aspects that we do at the foundations, we're very much open and we collaborate and license and work with folks because obviously, just like we can't do it without you all, we also need the help to then scale and market it and do in that kind of the scalable impact that it would have on patients. So we're very good and we've had experience now in doing that.
Sri, if you take the stem cells from an 80-year-old person, for example, and you develop it into RPE cells, are those cells more like a newborn or more like an 80-year-old?
Oh. Yeah. Yeah, very good question. Yeah, especially a question from the expert. I'm nervous now. It's hard to define the age of the stem cells or retinal cells that we culture in the lab. So we typically think if we grow for like 6 months, they're old, right? Because for AMD patient, for example, 70-year-old patient, we cannot mimic that cells, right? Because we can't grow for 70 years in the lab to exactly mimic the 70-year-old person retinal cells. So again, using the Nobel Prize winning CRISPR technology, we want to induce the aging, premature aging in the cells. So within like the few months, they will turn it into the aged cells. We do the genome editing. We treat with the various drug molecules. So these cells will get aged faster. So that like we can think these are the aged RPE cells or retinal cells, and then we'll test tons of compounds, drugs on those cells. Yeah.
But I guess when they first come out,
Yeah.
they really are like fetal embryonic. I mean, they're like you were born with at the original transformation because you basically rejuvenated in some ways the cells.
Yeah.
So I think they are. So there's still hope there.
Yeah.
So for new knees and who knows what, right?
If you take genetic material, or is the stem cells considered genetic material? And if you take it from someone who's diseased, will the stem cells end up being diseased?
Yes.
Is that how you wanted to ask it?
Yeah,
Sort of.
Yes.
go ahead.
I mean, like if you have a dominant case of something,
Yes.
so that's our question.
Yeah, definitely. If you have any genetic mutation, so when we convert that cell into retinal cells, as I mentioned, they carry the same genetic information. Obviously, they carry the bad genes as well. So again, using this new technology, we edit the gene. So we mutated gene, we correct, or like we fix that mutation and then compare with the healthy cells. It could be from the family members, so that it could be similar or same genetic information. We'll test like the diseased versus the normal, the family member cells, so that we will find out like what drug or like editing any gene will get into the normal cells.
So I need to be nice to my brother.
Yes, yes, that sibling that you didn't talk to, now it's time to talk to them.
Yeah.
So,
Thank you for this conversation. So when I look at this, I think of a Texas lawn. You know, it's green except for the big brown patch in the middle, and then you're adding this layer on top, and you're hoping that, you know, the soil underneath it or whatever is better because you've edited it, right? But I'm wondering, you haven't changed the original lawn, and so there is likely to be some sort of competition, right? How do you combat that? What do you have to prevent the original cells from basically just outcompeting, and then you have a big brown patch again in the middle?
right. So in macular degeneration in particular, you have to remember, the retina cells, one of the unfortunate aspects of retina tissue is it does not repopulate. So it doesn't, unlike certain goldfish, actually repopulates their retinas. Humans do not. So the idea behind other grasses growing, you know, these are already the cells that have been either dying or dead. They don't have the ability to repopulate. So the truth is, this is where it's an advantage for us. Unlike other organs in the body, where, for example, scar tissue is a major limiting factor. You compete against other cells coming in and forming scar tissue around your joints, around other places. The eye is one fortunate place where you don't have this competition, because the other cells that are around there are not truly they're not capable of competing for that cell. So in that way, we use to our advantage the fact that cells in the retina don't double or don't populate.
Fabulous. And then with that, does that mean that you hope that this might be able to be used as preventative treatment?
So again, you know, I think from where already what we're doing at the Retina Foundation, you know, if we look at, and this is just in disease in general, right? Prevention is much, much more powerful than treatment. And so this is major surgery, right? So when you do this kind of procedure, it's not a trivial surgery. And so we wait, at least right now when we have done the trials we've done, we've always done it in patients who have really severe vision loss and are the ones that are candidates. I think where we'll be on the prevention side is not directly injecting stem cells, but as Dr. Tripathi was talking, studying your stem cells from the patient and figuring out what treatment, pill, we have a little device that we can place on the eye, what are the other approaches we can use to prevent progression. Just like for those of us take statin, we take statins to prevent heart disease, we want to have a similar approach, but to then personalize it to figure out what's the exact type of drug people should be taking to prevent progression for their macular degeneration.
We're now seeing the use of stem cells in macular. Prior to COVID, we had a great lecture on the use of stem cells in genetic problems in the eye. What is the connection, and are the techniques, CRISPR or whatever, anywhere similar, and how are we making sure we connect those things? If
So there are direct approaches to correcting genetic mutations in the cells. So Dr. David Birch is one of the world's leaders in doing this in patients with inherited retinal disorders. But as he will tell you, if all the cells are gone, there's nothing more to correct. So the hope on the genetic correction approach, or the gene therapy approach, is to get in there while there's still something to be fixable and correctable. So there will be a point in which that technology, at some point where there is a pure genetic disease, will be appropriate up to a point, and then stem cells will replace that as a therapy. In macular degeneration, it's a little bit more tricky because the genetics are not as straightforward. There isn't one gene, one disease. So the idea of correcting a bunch of genes inside the cell for macular degeneration, a little bit more challenging. The only good news on the macular degeneration front is that it typically takes 70 years to get the disease. So even if we don't correct the stem cells, the hope is that those stem cells will last for another 70 years. And the majority of my patients who are 75 or 80, when I tell them it's good for 70 years, that's the warranty, they're okay with that. So.
It sounds like this can be used both for regeneration and treatment, meaning non-surgical. I'm still confused. How does the cell know it's not supposed to become bone or cartilage or liver? How does it know it's supposed to be an eye cell?
Oh, very good question. We know various factors, drugs that can make into the eye cells. So for example, when we are making the eye cells, sometimes they can accidentally differentiate into the heart cell. So I was showing a picture to my folks. So it was all accidental, like they're beating in the dish, like a heartbeat. So they could be the cardiomyocytes, which we don't want into the eye. So yeah, there are challenges. So for now, we worked hard for over 10, 15 years to generate these eye cells from the stem cells using different drugs we add into the dish in the lab. And then first thing is we will check for all the genes that are needed for our eye cell function. So there are a bunch of genes. When we test between the stem cell and the retinal cells, we should see all the genes that needs to be involved in the visual process. So we make sure we have all the content in the retinal cell, and then we take those cells and eventually inject into the patient.
Doctors, I recognize this is a panel on macular degeneration, and I don't want to be selfish, but out of my curiosity, I'd love to know how much of this research we see being transferable to other retina-related conditions. I was diagnosed with ROP when I was born, and I had a lot of classmates in my early schooling with retinitis pigmentosa and some other things, and so I just kind of wonder what it would look like to transfer some of this work. Obviously, you know, everybody can benefit from stem cell research, and everybody's got a retina, so could you tell us what that would look like?
And we'll talk about the organoids and
Yeah.
where you see.
Yeah. Yeah, that's the picture I have shown earlier. So we used to differentiate only into the one cell type earlier, but now using the latest technology, we can differentiate or make the stem cells into all cell types in our eye. So here we see like the photoreceptor cells that are needed for our color vision, like the light reception, and you see the dark retinal pigment cells, the same cells here. So they have like the pack of all the different cell type. So for example, if we want to study a mutation in one cell type, so we will create that mutation at stem cell stage, and we make those stem cells into the organoid or eyeball, and then we will use that particular cells for future transplantation or studying for the drug that are necessary to prevent that cell loss in the body.
That was terrific, and you added a degree of humor throughout that whole process too that helps. And I'd like to make a connection to what you guys said. Certainly, and we have an eye disorder in our family, and so it's very relevant to our situation, and everyone's in here in some way. But Carl, you mentioned the concept of hope, and I think that is certainly something that is vital to move a person through these situations. But what we have at the Retina Foundation is more than hope. What we have is knowledge and innovation and technology that will manifest and enable that hope to become reality. And I think in this area of age-related macular degeneration, I think you can see, and from our perspective, from a board level, and folks that spend a lot of time in this, we have two of the world's greatest, not just the Southwest region greatest, but two of the world's greatest in this particular area of macular degeneration. And then when you consider the other diseases that affect the eyes, as we talked about, inherited retinal diseases, and Dr. Birch and his wife, Eileen, who addresses pediatrics and has advanced significant technologies in that area. You know, we are building a world-class element of and core of resources to address the needs of our patients, because that really is what it's all about. Certainly everyone in this room, the sponsors, the volunteers, the staff, and our friends in the community are all important, but the end result is affecting in a positive way our patients. And so I thank you for being here this evening. I certainly thank the sponsors for the event, as well as our wonderful cocktail hour. We will continue these Eye on Innovation sessions on a periodic basis. Our next session is in November. For everyone in this room, we'll get you out an invitation on the subject matter and the speakers, and we hope you can attend. Because what would really be nice is that over a period of time that we continue as a family dedicated to research and dedicated to finding preventions and solutions to what we all in some way are dealing with. So thank you. Please drive safely home, and we look forward to seeing you in